Hello everyone, my name's Megan Bell. I'm a research fellow at the University of Western Australia School of Population and Global Health, and I'm pleased to be chairing this session on incarceration today. Apologies for my voice, it's a bit croaky and hopefully it holds out until the end of the session. I'd like to start by acknowledging the traditional owners of the lands upon which we meet today around the globe. I'm joining you today from the traditional lands of the Whadjuk people, and I pay my respects to elders past, present and emerging. We'll hear from 4 speakers today on the topic of incarceration, and at the end of the 4 presentations there will be some time for questions, but please feel free to add your questions to the Q&A throughout the session. The first speaker is Rohan Borschmann, who's a Senior Research Fellow in the Justice Health Unit at the Melbourne School of Population and Global Health at the University of Melbourne. A former prison psychologist and probation officer, Rohan's research focuses on the mental health of adolescents and marginalised young people in Australia, with particular expertise in self-harm and substance use. Rohan is also a practicing psychologist 1 night each week. Hey, Rohan, if you could please share your screen.
Yes. Is that all working?
Yes, it is.
Okay. Hello, everyone. Thank you for joining today's virtual session on incarceration. I'm going to be talking about an exciting study we've got going at the moment where we're examining mortality in people after they've been released from incarceration, and it's a multinational study. So just as a quick bit of background, we know that the global prison population is rapidly expanding at a rate much faster than population growth. The WHO has estimated that there's more than 30 million people released from incarceration each year around the globe. And we know that people who experience incarceration typically have really poor health profiles and sort of have higher rates of almost every physical and mental health condition that's ever been studied, including mental illness, NCDs, infectious diseases, self-harm and suicidal behaviours, poor dental health, sexual health problems, substance use disorders, including injection drug use. So perhaps as a consequence of that, we know that the risk of mortality is increased when people are released from prison. However, death is still a relatively rare event, speaking statistically. And so one of the problems that the literature suffered from so far is that even large studies don't have enough power to examine mortality in any kind of granular way, by looking at specific causes of death or looking at death in specific subpopulations such as women or Indigenous people or young people. And also looking at the time since release, which we know is a function, which we know changes mortality rates. So one of the literature limitations so far is that it's really been limited to 2-week blocks. So for example, the first 2 weeks after release. So ideally what we could do is just get a lot of individual level data from multiple studies and analyse them together, and then we'd be able to have the power that I mentioned has been lacking so far. But it's almost impossible to share individual data due to ethics restrictions and various legislative hurdles. So what we've done with this project is we've created a consortium of existing studies, and we're using the power of linked data and some novel analytic methods to really get as close as we can to having those individual data. So our study is called the Mortality After Release from Incarceration Consortium Study, the MARIC study. And it's a multidisciplinary, multinational study that's funded by the NHMRC in Australia. And the overarching aim of the study, and we have many sub-aims, but the overarching aim is to use linked incarceration and mortality data to comprehensively examine the incidence, timing, causes, and risk and protective factors for mortality in people released from incarceration internationally. So we're really looking at who is at what degree of risk and when after release. So just quickly run you through the study. We so far have 29 cohorts, existing cohorts of people released from prison from 11 countries. So these were existing studies that have already collected all of their data and kindly agreed to join forces in this consortium. The combined sample is almost 1.5 million people, so some of the studies are quite large. And as we know, many people are released multiple times from prison. So for some of the studies, we do have re-incarceration and re-release data. So we know that there are going to be many, many more releases than 1.5 million. We did some quick pilot data collection recently, and we found that in the first 12 weeks after release, we had more than 2 million releases. So that's just in the first 12 weeks. And we have data that goes back 35 years. So so far we have 82,000 recorded deaths, and almost all of those came from linked death indices, either state or national or municipal death indices. I think there were less than 100 that were recorded by other means out of the 82,000. And we have an astonishing 9 million person years of follow-up. So this is really going to change the power to conduct these analyses that I mentioned before. And given that it's involves 29 cohorts in 11 countries, we so far have more than 60 people in the consortium, and that seems to be growing by the month, which is really great. So this is a quick snapshot of the countries that are involved, and I think the first thing that jumps out here is this is not a global study, it's a multinational study. So most countries are not represented here and most regions are not represented, but what we do have is a large collection of studies, mostly from North America and Australia and Western Europe. But we do also have Malaysia and Taiwan and New Zealand and some countries that are outside of those core regions. So we're going to be doing an individual participant data meta-analysis, and just briefly, I'll talk you through this quickly. So this is where each local study has kindly agreed to analyse their data, again, using some predetermined methods that we will send them via a statistical analysis plan for each paper. And then they will share the aggregate outputs of those with us, which gets past the data sharing hurdles that I mentioned. So once we get those aggregate outputs, then our analysts here will be conducting meta-analysis to produce the outputs that we want. This is just a quick visual representation of that. So the top row there, study 1, 2, 3, ours will go up to study 29. So some of the strengths of this approach are that it allows for unpublished data to be included, because each local cohort will be reanalyzing all of their data set. It increases the power, obviously, considerably compared to the individual studies, and we'll be using a consistent confounder. We can adjust for consistent confounders. We can also look at state, country, region level parameters that might impact mortality. So we'll be using meta regression to do that. And probably most importantly, it overcomes the data sharing hurdles that I mentioned before. In terms of some of the limitations, almost all of the cohorts do come from high-income Western countries. So if anybody is aware of any cohorts from other countries, we're definitely keen to further collaborate. Most of the sample is male, although this does reflect global incarceration rates. And also one of the benefits here is that we do have data relating to 145,000 females, which is much more than any other study so far in the literature. We also have some quite wide heterogeneity in some of the cohorts, because some of them have only sampled people with HIV, for example, or people seeking opioid substitution treatment. And they can reflect different mortality risks. But we were going to use these specific cohorts in some different localized targeted research question papers in the future. And also, not to mention the challenge of simply coordinating 29 cohorts across 11 countries, which has felt a little bit like herding cats at times. Some of the strengths of this study, the very large numbers that we have, of course, 1.5 million people across multiple regions of the globe. The approach we're using does eliminate the data sharing restrictions that I mentioned, and we now will be able to look really in a really granular way at mortality. So we'll be able to look at daily levels instead of just 2-week blocks or 4-week blocks. And because we have so many deaths and so many person years of follow-up, we really have the ability to disaggregate the data many different ways. So we're planning a series of papers looking at specific causes of death, but we can also look at time since release, and we can also look at key subgroups such as Indigenous people and women, like I mentioned before. And importantly, this really facilitates a really genuine collaboration between different cohorts and regions of the world. And you can see here, this is the protocol paper that we had published last year, and just you can look at the author list there and see that there really are a lot of people involved in this project, which is really fantastic. A quick summary of what we're doing at the moment. We have recently circulated the statistical analysis plan and request for data for our main headline paper, which we're going to look at the incidence of all cause and cause-specific mortality following release, and look at individual level risk factors only for mortality. So we're hoping to submit that sometime in the first half of next year once we've collected and analysed the data. And also, we're just about to submit a follow-on funding application where we have more cohorts included. We're going to extend some of the linkages, and we'll be able to look at the first 9 months of deaths related to COVID in 2020. These papers here are what we have planned. So far we have 7 lead authors leading these 7 papers, putting together the statistical analysis plans for next year to circulate. And I've written here, lead authors welcome. We're always keen to collaborate with people if anybody's got any areas they'd like to examine using this large data set. And some of the papers that we also have planned following on those are listed here. And we'll be able to use different cohorts to answer different questions. So these are this is the team so far that I'd like to thank, and I think this shows what a fantastic team effort it is to get to this stage. So I'd like to thank the entire team, and also thank you for your time today. I hopefully haven't gone over, and I'm looking forward to some questions and answers after I think Jessie speaks at the end. So thank you very much.
Thanks, Rohan. You did very well on time there. We're now going to hear from Professor Stuart Kinner, who is Head of the Justice Health Unit at the University of Melbourne and Head of the Justice Health Group at the Murdoch Children's Research Institute. Stuart chairs Australia's National Youth Justice Health Advisory Group and the WHO Health in Prisons Program Technical Expert Group. He's also a member of the WHO Steering Group on Prisons Health. Okay, Stuart, if you could please share your screen.
All good?
Yes.
Great. Thanks, Megan. Look, I just want to start by acknowledging my 2 fantastic co-authors. What I'm going to present is a paper that's currently under review, and it's one of a few papers based on this quite remarkable cohort of based on data linkage in BC and Canada. Dr. Wenqi, who you'll hear from next as well, who was very generous with his time in doing all of the data analysis for this work, including all of my annoying requests for minor changes to the analyses. So thank you very much, Wenqi. And also Dr. Amanda Longwhite, who's the principal scientist responsible for the provincial overdose cohort that I'll talk about. I just want to very quickly acknowledge the BC Centre for Disease Control, who were kind enough to give me access to these data through Wenqi for doing this work. The Peter Wall Institute for Advanced Studies at UBC, who invited me over as a visiting research scholar last year to commence this work. So thank you to Peter Wall and NHMRC for salary support for me. Very briefly, the background for anyone who's unaware. Many parts of North America, including BC and Canada, are in the throes of a sustained overdose epidemic that commenced really in 2006. You can see here in the graph some data showing, particularly for males, the quite dramatic increase in rates of illicit drug overdose death from 2016 into 2017, and that's been variable but quite sustained in the years since. Some promising declines in 2019, but unfortunately in the context of the COVID pandemic, as you can see, their rates climbed again quite dramatically. So a really, really concerning phenomenon. In BC alone, many thousands of people have died from fatal overdose since this epidemic began. So that's at the population level. One other thing that we know is that one of the groups that's at particularly high risk of fatal overdose is people released from prison. So Rohan was talking about the fact that there are 29 cohorts in his international consortium. One of those is this cohort from Queensland from many years ago. And what it's showing here is a very predictable phenomenon in this study. Like most of the studies that Rohan's talking about, we link correctional records with death records. And what you're seeing there is the number of deaths from all causes by week after release from prison. You can see there that quite remarkable spike in deaths immediately after release from custody. And if you look at the breakdown, particularly in the first 30 days after release from custody, and this is in Queensland, in Australia, in the absence of an opioid overdose epidemic, 38% of all deaths in that period were drug and alcohol related. So, of course, taking all of that together, it begs the question, what's happening with overdose deaths among people released from prisons in BC in the context of a sustained opioid overdose epidemic, and what can we do about that? So the data I'm going to talk about here are from the provincial overdose cohort, POC. What I'm not going to talk about, another presenter at this conference will talk about, is the main part of that cohort, which is a sample of all people who experienced a non-fatal or fatal overdose. So that's what's typically referred to as the provincial overdose cohort. But as well as establishing that cohort, BC CDC established a random 20% sample of the provincial population, all people, or not nearly all people, everybody on the health insurance register, MSP in BC. And the data that I was working with are from that random sample of 20% of the entire BC population. And so within that 20%, we sampled all people who were aged 18 or older on the 1st of January 2010. And then, of course, really narrowing it down, of those people, those who were released from a BC prison at least once during the period 2015 to 17. So it's a bit of an unusual design, and I'm going to just take a moment to explain this to you. You can see here that we have effectively 5 years of retrospective data linkage. So 5 years where we've linked across multiple databases, I'll explain, to identify risk factors for overdose in the cohort. And then a period of observation. This paper was describing the cohort. At that time, the period of observation for overdoses was just under 2 years, so 2015 and most of 2016. That's continually being updated, and for the purposes of the paper that we're presenting here, we continued the linkage to ascertain overdoses up until the end of 2017. So effectively, we have 5 years of retrospective linkage to ascertain risk factors for overdose, and 3 years in which people can enter the cohort and in which we can observe overdose outcomes. Without dwelling on it, the provincial overdose cohort is a remarkably rich multi-sectoral data linkage project. You can see in the left column of this table the many databases that were combined together to ascertain overdoses. So it wasn't simply going to just ED records or just any one particular form of record. So it was a very, very sophisticated process for identifying overdose. And as you can see on the right, there were a range of other health and social databases linked as well. And I think this is a remarkable strength of this cohort, the richness of the data that can help us understand the trajectories for this extremely vulnerable high-risk group. Just to give you a sense of where the overdoses in the cohort came from, you can see they've come from a diversity of sources and often from more than one source. I won't dwell on that in the interest of time. So very quickly, what do we find in this particular study? The cohort of interest here is 6,106 people who were released from prison in BC over the period 2015 to 17. That's about 14,000 occasions of release because so many people churn through prison multiple times. We followed them for an average of 1.6 years. And as we, consistent with what we know about people in prison, the vast majority were male and most were young-ish men. So during the period of follow-up, 77 members of that cohort, 1.3% died of any cause, and 48 of those, so 0.8% of the whole cohort, died from an overdose. Now, those numbers may seem relatively small, and of course that's important to power, but the incidence of overdose death in this cohort is 11.2 per 1,000 person years. And just for reference, the population rate of fatal overdose in BC at the moment is 0.03 per 1,000 person years. So very, very different. We wanted to have a look at risk factors for all-cause death and for overdose death. Just very quickly, what I'm showing here is just, in the interest of time, selected risk factors from a multivariable Cox regression model. And the red dots are the adjusted point estimates for the hazard of death according to each of these risk factors. The grey dots for comparison are just the unadjusted hazards, just so you can see how much those associations attenuated in the multivariable model. So what we found first, if you look at the number of incarcerations, that's what INCARC is, you can see that there's a sort of a dose-response relationship, and this has been shown in other studies as well, between incarceration and risk of death. In other words, the more time people are incarcerated, the greater their risk is of dying in the community after those episodes of incarceration in a dose-response fashion. We used a thing called the Elixhauser Comorbidity Index to look at physical comorbidities and found that even after adjusting for confounders, people with physical comorbidities were at double the hazard of dying during follow-up. People with dual diagnosis had, as you can see there, the unadjusted hazard was 4. That attenuated very dramatically in our adjusted model, and that's something we want to explore more closely because we do know from other work that dual diagnosis is a very important risk factor. And people who were taking opioids that are being dispensed to them for pain, not dispensed to them as a substitution treatment for opioid dependence, as you can see there, had an almost 4-fold increased hazard of death even after adjusting for confounders. Same thing when we look specifically at overdose death. The pattern is very, very similar, although partly due to the smaller numbers, many of those associations are not statistically significant, but a very similar pattern emerging. That's consistent, of course, with the fact that 2/3 of the deaths in the cohort were overdoses. The one other thing that we wanted to have a look at is the timing of deaths, and you can see here that deaths occurred very disproportionately just after release from prison. You can see here is the incidence rate in the first 2 weeks after release from prison due to overdose. So consistent with previous research, very high. I'm out of time, so I'm going to skip the strengths and limitations and focus on what we think this means. The first thing is that 2/3 of the deaths almost in this cohort after release from prison were due to overdose. And what that tells us is that even though BC's been doing a fantastic job with doing some of the things we need to do, opioid agonist treatment, making naloxone available, that alone has been inadequate. And our evidence is consistent with calls from a broader multi-sectoral response to preventing deaths in this population. We observed, consistent with others, a dose-response relationship between incarceration and death. And it suggests, of course, that diversion from incarceration, as well as saving the public money, can be construed of as an overdose prevention measure as well. We saw that opioid dispensing for pain increased the risk of all-cause death and overdose death. And that, of course, points to the need for enhanced clinical supervision and probably some targeted harm reduction for this very at-risk population being prescribed opioids for pain in their transition from prison to the community. We saw that physical comorbidities and dual diagnosis, so co-occurring mental illness and substance use disorder, increased risk. And of course, that's consistent with what we know about people churning through prisons, which is that neither coordination of care nor continuity of care is adequate. So these are resolvable system problems that we're revealing through this multi-sectoral linkage. And lastly, we saw that remarkable spike in overdose deaths immediately post-release, which points to the need for a concentration of effort in that immediate post-release period to really substantially reduce preventable deaths in this population. Thank you.
Okay, Stuart, are you still? Okay, there we go. Thank you very much, Stuart. I'd just like to remind everyone that if you have any questions throughout the presentations, please add them to the Q&A function within your conference screen. Next up, we're going to hear from Dr. Wenqi Gan, who is a statistician and data linkage lead for the Provincial Overdose Cohort Group at British Columbia Centre for Disease Control. Dr. Gan received systematic training in clinical and preventative medicine, environmental and occupational health, especially methodological training in epidemiology and biostatistics. Wenqi, would you like to share your screen, please?
Sure.
We have been having a few technical difficulties with Wenqi's screen sharing, so we'll just give it a minute to see if it works.
You need to give me a permission to share the screen. I think, okay, how about right now?
We can't currently see your screen. Are you able to share it?
About right now is yeah, after I share that the video is stopped. I need a permission to share the screen.
Okay.
can you provide a permission? Yeah.
Yep, permission has been provided.
Can you see me? Can you see?
We can see you, but we can't see your slides.
Oh, okay. How about the, after I share my screen, my video was stopped. So I need to get permission to share my video.
All right. We might just get tech support to share your slides if that's okay, Wenqi, and then you can talk to them and let us know when the slide needs to be changed.
Yeah. Oh, yeah, this is slides. Okay. So what should I do?
So Wenqi, Stuart's sharing your slides currently. So if you just talk to your slides and let Stuart know when you want to change to the next slide.
Oh, okay. Okay. Thank you so much. I will introduce a cohort study about the risk of overdose-related death for people with a history of incarceration in British Columbia, Canada. Next slide. The main objective of this study to examine whether or not people with an incarceration history were more likely to die from fatal drug overdose compared to people without an incarceration history. In addition, we also examined the number of previous incarceration or cumulative duration of previous incarceration was associated with the risk of fatal overdose. Next. We used the cohort study to examine the risk. This cohort study includes a 5-year exposure period and a 3-year follow-up period. During the 5-year exposure period, we identified people who had an incarceration history. We used the data of provincial incarceration records to identify the persons with an incarceration history. During the 3-year follow-up period, we identified the person who died from drug overdose. We used the provincial coroner service data and the vital statistics data to identify persons who died from drug overdose. Next. We used the Cox regression model to examine the risk of fatal overdose for people with an incarceration history compared with people without an incarceration history. In the multivariable analysis, we adjusted for age group, sex, comorbidity, substance use disorder, SUD, mental illness, revised the Alex Hauser comorbidity index, dispensation of opioids for pain, dispensation of benzodiazepines, neighborhood material deprivation index, and region of residence. Next. Next slide. So this is a very large cohort study. At the baseline, mean age is 50 years. 59% were male. During the 5-year exposure period, we identified more than 5,700 persons with an incarceration history. During the 3-year follow-up period, we identified 634 persons died from drug overdose. You can see that people with incarceration history, the mortality rate is very high, 897. per 100,000 person years. But for people without an incarceration history, the mortality rate is pretty low, 22. So compared with people without an incarceration history, people with an incarceration history were more than 41 times more likely to die from drug overdose. After adjusting for all the covariates, the hazard ratio is 4. We can see there is a huge reduction in the risk estimate. Next, please. Next, this table is to examine how these personal and neighborhood characteristics affect the effect estimate. The column single adjustment shows that adjusting for substance use disorder, SUD, reduced the crude HR by 84%. Adjusting for each of other covariates reduced the crude HR by 13 to 28%. The multiple adjustment column shows that in the model including SUD, further adjusting for all other covariates reduced the crude HR by 7%. In summary, this table shows that substance use disorder is an important confounder for the association between previous incarceration and the risk of fatal overdose. Next, thank you. Next. This figure is to show the relationship between the number of previous incarceration and the risk of fatal overdose. X-axis shows the number of previous incarceration. The bottom figure is for unadjusted HRs. The top figure is for adjusted figure. The bottom figure shows there is a strong linear trend between the number of previous incarceration and the risk of fatal overdose. The top figure shows that after adjusting for all the covariates, the linear trend was no longer evident. Next, thank you. Next slide. Yeah, this figure is to show the relationship between the cumulative duration of previous incarceration and the risk of fatal overdose. X-axis is for the quartile of cumulative duration of previous incarceration. The bottom figure is show unadjusted hazard ratio. The top figure shows the adjusted hazard ratio. Again, the bottom figure shows there is a strong linear trend between the quartile of cumulative duration of previous incarceration and the risk of fatal overdose. The top figure shows that after adjusting for all the covariates, the linear trend was no longer evident. Next, thank you. Next slide. So this study has some strengths. This study cohort is based on a 20% random sample of general population in British Columbia, Canada. The sample size is very large. The sample is representative of the general population. And in this study, we were able to control major confounding factors, especially substance use disorder. The major limitation of this study is that the incarceration information was only available for provincial correctional facilities, but was not available for federal correctional facilities. This situation may potentially cause non-differential exposure misclassification, which could cause underestimation of the risk of fatal overdose. Another limitation is that this study is based on linked administrative health data. Some individual risk factors, such as personal socioeconomic status, were not available and could not be controlled in the data analysis. Next. So in summary, based on a large cohort study, we found that previous incarceration is associated with more than fourfold increase in the risk of fatal overdose. And we found that substance use disorder is a major confounder. Previous studies that did not control for SUD would potentially overestimate the true risk of fatal overdose. In this study, we did not find a clear linear trend between the number or cumulative duration of previous incarceration and the risk of fatal overdose. Thank you. That's all.
Thank you, Wenqi. I'm glad we were able to get your slides working and you were able to give your presentation this morning. Thank you. And thank you to Stuart for driving those slides. Last to speak in this session is Dr. Jessie Young, who is an NHMRC Emerging Leadership Fellow in the Justice Health Unit at the University of Melbourne, specialising in psychiatric epidemiology with expertise in data linkage methodology. He is a member of the Australian Institute for Health and Welfare's National Prisoner Health Information Committee and Technical Expert Group. His research has informed international clinical guidelines for the treatment of substance use disorder and the prevention of overdose. Thank you, Jessie.
Thanks, Megan. Can everybody see those slides okay? Yeah,
yes,
we're good.
Can.
Great. So I'm just going to present a bit of a work in progress, but something that we have some preliminary results. So I'll just dive right in the interest of time, just noting my grant and research support here. And also I have no actual or potential conflicts of interest in relation to this presentation. Again, I'm just going to walk through a bit of background, go into the methods really briefly, talk about the fun stuff, the results and conclusions, and then explain a bit about some future directions as this is a work in progress. So I'm talking about young people involved with the youth justice system, and what we know about those individuals is they have multiple and complex health needs, and I've kind of put a laundry list of things below there. I'm not going to go into each one in detail, but suffice to say that youth in contact with that system are at increased risk of a number of poor health outcomes and also kind of social vulnerabilities. So as we've heard today from Rohan and Stuart and Wenqi, there's strong evidence that adults released from prison are at increased risk of death, and overdose is the leading cause of those deaths. However, when we look at the young people released from youth detention, there's little evidence on the risk of death among those vulnerable young people. So there's been few studies traditionally done in small samples, and many of those studies are kind of subject to some selection bias. You know, there's been striking differences in the leading causes of death in these studies. So in the US, it's among young people released from youth detention, it's violence. Whereas if we look at the small amount of studies that's been done in Australia, it's kind of accidental poisoning or overdose. So there's still kind of some need to kind of clarify that on a large scale. And there's been some gender differences observed among the causes of death and also the patterns of death. However, no study has examined the broader contact with the youth justice system. So I was mentioning release from youth detention, but in the youth justice system, you can also be charged with an offense that doesn't lead to an order. You can have a community order, or you can be subject to detention. So there's kind of a a wide spectrum of contact with that system that hasn't been investigated. So that's essentially in this project what we set out to do. Stuart was funded to look at this in a very large fashion. So essentially what we did is we linked youth justice records from Queensland, Australia, to the National Death Index, which is obviously a federal death register. And then the AIHW integrated those records for us and provided us with de-identified data for analysis. Just to revisit, so the sampling frame was any youth in Queensland who came into contact with the youth justice system, that is, either received a charge, a community order, or was subject to detention in that youth justice system. And that basically the accrual period of those individuals into the cohort went from January 1st, 1993 to the 31st of December, 2014, so a 21-year period. And then we had death data, which spanned that period and an additional 3 years of follow-up after our accrual period. So that was from, again, January 1st, 1993, all the way up to the 31st of January, 2017. We determined overdose from the principal cause of death in the death records. We calculated crude mortality rates overall and stratified by Indigenous status and gender. And we also calculated crude mortality rates separately by the deemed intent of the overdose and also the drug type, so whether it was prescribed or illicit. So over the accrual period, 49,228 young people had 529,000 contacts with the youth justice system. So as you can see, this is a very large number of vulnerable youth. And as Stuart has mentioned before, people tend to have multiple contacts with the justice system over a relatively short period of time. That's why there's so many contacts there. And again, those contacts include charges, community orders, or detention. The majority had finalized charges, but no orders or detention. So obviously there's a lot of contact at that kind of entry level end of the youth justice system. And only 16% had one or more detentions. Over the follow-up period, there was 1,452 deaths, and 204 of those were classified as overdose deaths. 91% of those overdose deaths were determined to be intentional, according to the death records, and 54% were due to prescription medications compared to illicit drugs. This just gives you a flavor stratified by Indigenous status and also gender. So as you can see there, not all subgroups in contact with the youth justice system experience the same rate of overdose death. So one of the outliers that you can see there is this non-Indigenous male compared to an Indigenous male death rate. And then when we looked at intentional versus non-intentional, again, there's some differential patterns here, but the overall resounding kind of take-home message here is that the majority of the overdose deaths were classified as intentional versus non-intentional. And then when we looked at prescribed versus illicit, again, there's some subgroup differences here. However, the difference between prescribed and illicit did not reach statistical significance, as you can see in the far right of the graph there. So just a few preliminary conclusions that we can draw here is that young people involved in the youth justice system in Queensland are at increased risk of preventable overdose death. And the CMRs that we've generated thus far are about 4 to 10 times higher than in the general population of youth. So we also generated some evidence that risk differs across subgroups. So what we would suggest there is that a one-size-fits-all approach to prevent overdose is unlikely to be efficient nor effective. So it should be a targeted response. And contact with the youth justice system is an obvious opportunity to identify substance use problems, initiate treatment, and critically ensure continuity of care for this vulnerable group of youth. The other thing is that obviously we kind of observed some differential patterns among Indigenous youth compared to non-Indigenous youth. And that would suggest that some culturally appropriate interventions are needed just to make sure we're targeting and providing the best level of care to those vulnerable subgroups. So some future directions. We're just in the midst of kind of refining and cleaning our adult corrections record linkage for this cohort. And so that's going to allow us to account for time spent in adult custody. So we're going to be able to adjust for that time because the risk of death changes when you're in custody versus in the community. Obviously, as Stuart and others have presented, there's a large spike when you get released from adult custody. So we're going to be able to do some work to account for that and look at the effect of that. We're going to calculate standardized mortality ratios. So the comparison with the general community was a very crude comparison that I presented. We're going to be able to get much more specific with that comparison. We're going to examine drugs as a contributing cause. So we're going to go into kind of the secondary diagnoses, et cetera, and pull out what, drugs potentially contributing cause to death, not just the principal cause of death. We're also going to be looking at the probability of overdose death and identify predictors of that probability using a competing risks regression to account for causes of death other than overdose. And also, we also have the ability, and we already have this linked into the National Coroner's Information System. So it's basically coronial records, and we're going to be able to understand more of the circumstances leading to these overdose deaths. And that's really important to kind of direct potential preventive interventions or prevention in this area. And we're also, through those records, going to be able to look at toxicology as well. So potentially tease out, things like polydrug use as a contributor to these overdose deaths. Thank you for your time.
Thank you very much, Jesse. So we'll now take some questions. There have been a few in the Q&A that Stuart has already answered, but I thought I'd just read those out in case other people in the audience had similar questions. Stuart, if you don't mind responding to them again. So one of the questions was that you've mentioned that there was 1.6 years of follow-up in the cohort. Is it only to death, or have you censored those with no record in the data? If yes, how?
Yeah, so just to clarify, in the paper that I presented, we looked at median follow-up time in the community. So in other words, we removed all person time spent back in custody. And that's because the risk of death in custody is so much lower than it is in the community. So it's 1.6 years median community follow-up. We censored at deaths using BC death data. Things that we couldn't censor for were migration out of the province. And the important thing that we couldn't adjust for is federal incarceration. In BC, there's 2 tiers of incarceration, people in provincial systems and people in federal systems. And because we only had provincial correctional records, we couldn't adjust for when people went from a provincial prison or from the community into a federal prison. The consequence of that is that we underestimated the incidence of overdose death in the community, because some of the time in our denominator that we were calling community time was actually time spent in federal prisons, and we have no idea how much, but we do know, therefore, that our incidence estimates are conservative.
Okay, thanks, Stuart. The next question was also for you. Are you able to report the results by Indigenous status?
Yeah, and Wenqi may, because he works much more closely with these data, may have comments to add as well. We didn't. My understanding, and perhaps Wenqi could confirm, is that the ownership of that variable in BC is under the control of the First Nations Health Authority, which I think is consistent with notions of Indigenous data sovereignty. And so, in other words, it's not appropriate for me as someone from Australia to come in and start examining that as a risk factor without the guidance and support of First Nations people in BC. So no, we didn't. But as I said in the comment there, we did do that in Australia a number of years ago, and very much consistent with what Jessie presented. What we've seen is very different patterns of substance-related mortality for Indigenous and non-Indigenous people. That's important because the narrative around this issue is so heavily focused on opioid overdose. If we don't also invest in prevention for Indigenous people who may be more likely to die from, for example, alcohol-related causes, we're systematically disadvantaging Indigenous people further. So it's a really important comment.
Thanks, Stuart. There's one more question on the Q&A for you, but then I have some questions to follow up after that. If anyone would like to add more as we're talking, please do. There was another question that you've already answered online, Stuart, regarding the spike in overdose deaths immediately post-release. It also happens that people discharged from inpatient mental health care in hospital are at a higher risk of suicide immediately post-release. Can you comment, do you think there are any commonalities in why this might be?
Yeah, absolutely. There are differences, but there are commonalities. And in fact, Elizabeth Merrill and Sheila Bird showed a similar phenomenon for overdose among people discharged from inpatient drug and alcohol treatment. And so, we know that there's this phenomenon where people transitioning out of institutional settings experience an acute period of risk. And I think broadly speaking, that's about failures of transitional care. We know that people often come from difficult circumstances into institutionalized settings. And so unfortunately, what we do is invest in those very expensive acute settings and then fail to invest in transitions back to the community. And so it's unfortunately not surprising that we see a continuation of poor outcomes for those people. So the lesson here across all of these settings is the critical importance in investing in transitional support for people, so that the investments that we make in expensive inpatient and institutionalized care aren't lost.
One of my questions is whether, it's probably relevant to all four presenters, is whether you have any information on the programs that these people participate in while they're in prison. So whether they participate in any drug rehabilitation programs while in prison.
I think I can answer quickly from my study, and I'm probably the least qualified out of the studies because we're linking really incarceration data with mortality data. But some of our studies in the consortium have sampled specifically people who are seeking substance use treatment. But each of the cohorts in our consortium has given us some very broad indication of whether or not there's any kind of history of mental health problems or any kind of history of substance use problems. But we don't have the rich survey data that Stuart and Jessie have. So that's my 2 cents worth.
In my particular study that I presented, we didn't have information as to what programs that youth were involved in during detention or even in community orders. I think we've looked at that, Stuart and I have looked at that in a prior study of adults in Queensland, where we asked people in prison through survey, basically, were you involved in programs of those types? And I think, anyways, of speaking for me, my learning in this area has been that those are important. However, they're not sufficient if they're not continued after release into the community. So it's really about, initiating those programs, but critically ensuring that there's continuity of that type of care and support as they get released. Otherwise, what we know is things fall apart really quickly.
The one thing I just add to that is that an absolute challenge in this area is that correctional records are typically very spartan, so it's not usually possible to get much. So one of the great strengths of the provincial overdose cohort in BC is this 5-year period of ascertaining exposures through retrospectively linked data. So you may just know from correctional records that someone is in prison, but you can see in the 5 years before they went into prison that they had multiple ED presentations for substance use, mental health problems, and so on. So that's a way of kind of characterizing their history of risk factors and morbidities.
And improving sorry, just to add to that too, Megan, I think it's really important to acknowledge that improving both the capture of, the quality of, and the availability of prison health medical records for this purpose would be a huge, huge benefit, I think, in this area, because currently between admission and discharge from prison, it's currently, from a health perspective, a black hole.
Yeah, that's been my experience too. The feedback that unless someone's participating in a program relevant to their sentence, then the information's not available. But it seems like a very important feedback to the government that these programs don't do anything for inmates once they leave. I'm also interested in whether you've got any information on where people go when they're released. Are they reunited with families? Are they, linked up with employment services? Anything like that?
Once again, Megan, my study is not. It's just a very broad brush study. So I'll say no and sit back for Stuart and Jesse and Wenqi.
Our in British Columbia, the provincial overdose cohort is set for the purpose of overdose monitoring. So we don't have the data on situation after release from incarceration. Yeah, that's a very important question.
And in the study that I presented, the answer is no. However, I think that really highlights the importance of future multi-sectoral data linkage studies, and usually, best practice would be to do a mixed methods design where you complement the data linkage component with some form of qualitative methodology where you take a subset of the individuals or the sample population and really dive deep into how things go for them in the community after release.
Yeah, I couldn't agree more. And I think one of the ways that people are, including our group, increasingly doing that is to try to include the voices of people with lived experience. It's one of those things with the data linkage that it's so easy to sit in your office in front of your database and not think about the actual people that the numbers represent. But, harnessing the voices of people with lived experience to help you think through what those data mean can really improve their translational value, I think.
Hey, Megan, there's a couple of Q&As for me. Did you want me to just answer those in? Yeah.
No, I was just about to read those ones out. Thanks.
Okay,
Jesse.
thanks. Yeah.
So the first one to Jesse, do you analyse by offence type? Is it possible that there are differences between youth charged for property offences and youth charged for drug-related offences?
Yeah, so we've just cleaned those particular data, and that's kind of one of the primary next steps to look at the most serious offense for those youth, both at a charge, order, and detention level, and see how that potentially predicts the unfortunate outcome of overdose death in the community. It's a great question.
The other question for you, Jesse, why can't you link criminal justice data to mortality for across the country using MADIP? That way you could learn more about preventative as well as risk factors, for example, employment, incomes, etc. That's the first part of the question, so I'll let you answer that.
Yeah, sure. Luke, I would love to do that. So if you want to facilitate access to unit record data for MADIP, I'd love to do that study. And I think it would be highly competitive for grant funding. So we could look at doing that. The reason we haven't is simply because the approvals required, and I guess the gatekeeper approval in particular is rather challenging and always is in this area, and it just takes time to convince particular data custodians who are not used to releasing data for public consumption to kind of form a relationship and get access to those data. But MADIP sounds like an incredible resource, and we've had some preliminary conversations in that area, but we would love to do more, obviously.
The second part to that question, Jesse, wondering if the demographic differences might be related to the higher use of prescription drugs influenced by affordability.
Yeah, I mean, that's something to consider. I think, overwhelmingly in Australia, we actually have a really affordable kind of access to prescribed medication system, relative to the rest of the world. However, as you point out, I mean, the youth, released from the youth justice system are probably, we know that they're from disadvantaged and entrenched kind of financial hardship backgrounds. So it would be interesting to look at, their concessional status versus, what they need to pay out of pocket, and how that kind of translates to different subgroup patterns in overdose death. I mean, I think that would be really useful. And of course, to do that, we would have to then link in kind of our federal level PBS information, which is possible. And maybe Stuart can comment on another study which is going to do exactly that.
Yeah, look, we multi-sectoral data linkage involving state and territory data and Commonwealth data is exactly where we need to be going. And even though, this is what this conference is about, even though that's technically possible, in Australia, which I think is doing reasonably well, it is an absolute nightmare. We are very experienced at doing this, and we're now almost 2 years into having a full-time, highly qualified person navigating us through all the necessary approvals. And that's not to have a go at any of the data custodians or the data linkage units. It's just that there's so many of them. So to do this kind of work well, multi-sectoral, multi-jurisdictional work, there's a lot of work still to be done to synthesize and harmonize the processes so we can get on with doing the research and not spend years getting to the start line.
Just on that, I've got a question for Rohan. How long do you think it will take to do this project? It seems like a massive undertaking.
It absolutely is. We once sent out a request for data, it was last year or the year before, to summarize the first 12 weeks of data after release, mortality. And it took us about 5 months to get all of the cohorts to give us their data for that particular question, which, again, like Stuart said, not having a go at any of those data custodians, but there are 29 of them. So for each paper, what we're planning to do, we've got a really fantastic analyst, Claire Keane, who's putting together quite detailed statistical analysis plans that are trying to preempt and troubleshoot any problems that might turn up, because each time we reach out to the consortium, we have to reach out to 29 people or 29 groups. So we really want to minimize the burden on them. So we're sort of double and triple checking everything at each step, which obviously adds time to the process. But for the main headline paper, which will be the first data-driven paper from the consortium, we're hoping to have it done within 6 months. It's been about a month now since we sent out the data request. I might be wildly wrong with that, but that's based on our previous experience. That's what we're hoping and planning for. And then subsequent papers will be sent out all together so that, again, we're not bothering people for each paper.
5 months doesn't seem too bad, actually.
Well, again, I'll get back to you if and when it's done, but yeah, I'll let you know.
Okay, thank you. I had another question for Wenqi. Why do you think there was no linear relationship between the frequency and duration of incarcerations and the opioid-related deaths after you adjusted for your...
Okay. In the crude model, without adjustment for covariates, you can see there is a very strong linear trend between the number of previous incarceration and the risk of fatal overdose. But after adjusting for the covariate, the linear trend was not evident. But in statistics, the linear trend is very significant. P-value for trend is less than 0.01. But by visual, you can see the linear trend is not evident.
And why do you think that's the case?
I think probably the covariates played a role for the linear trend, especially for SUD, substance use disorder, lead to that evident linear trend.
Okay. Thank you. If there are no more questions from the audience, I've seen Luke has said PBS is in MADIP, so if anybody wants to follow up with Luke about some of these opportunities, I think he's got lots of information to share. But I think we've covered all the questions in the Q&A. So I'd like to thank all the presenters for some really fantastic and interesting presentations. A lot of exciting research going on, and great to see all those collaborations happening as well, which is one of the beauties of linked data, being able to link up across the world. So that's really fantastic. The recording of this session will be available on the conference platform in 48 hours time. So if you enjoyed this session, you might also be interested in some of the today's featured on-demand videos and posters, and you can find these in the on-demand gallery. Okay, thank you again to all the speakers, and hope you all have an enjoyable day.
Thanks, Megan.
Thank you.